Hi guys, this is Dr. Charity Stanley, and today we are talking about assessment of the renal system, the kidneys, and also the urinary system. You will notice on momentum that the chapter numbers are a little off. This is due to the new textbook. So the one that's listed as chapter 57 is in fact chapter 60 and what we're going over today. So big things that we're looking at with the kidneys are a filter of the body. They work together with the liver, and the kidneys are towards the person's back. They'll often complain of flank pain when there's actual problems with the kidney. But the kidneys have to have a good blood flow to them so they can function appropriately. And from the kidneys, you're going to see ureters come down. Those are gray structures that go into the bladder and dump the urine into the bladder. And the bladder holds the urine until it's time for it to come out and it to be squeezed through the urethra on the way out. Be sure to know the difference in ureters and a urethra. So the kidney's goal is to provide fluid and electrolyte balance and help to regulate acid-base balance within the body. The kidneys also activate vitamin D. Remember we talked about with parathyroid hormone, that parathyroid hormone and vitamin D are activated in the kidneys. Then travels to the stomach to open up the doors to allow calcium to be absorbed from the foods that you eat. The kidneys also produce erythropoietin. Erythropoietin, we talked about it during hematology. Erythropoietin is one of the chemicals that makes the red blood cells. So structures of the kidney, we have different aspects of the kidney. And so basically what's happening is the blood flow going to the kidney is going to be dissipated and shared out among all these small individual filters called nephrons. And so these nephrons will then produce urine that will be dumped into the minor calyces that are then dumped into the major calyces, which are the bigger cali, to be taken out from the kidney through the ureter and excreted with urine. So here's anatomy of the nephrons, and you've gone over that in anatomy and physiology. So we're not going to go over that right now. We're just going to keep moving. So what happens to your kidney as you start to age? Your kidney tends to decrease with the blood flow to it, and that contributes to some of the loss of the capacity of the kidney to be able to filter. So additionally, a lot of people end up with hypertension in older age, and that too contributes to decreased kidney function. So your blood flow to your kidneys starts declining at the fourth decade of life, so over the age of 40. It starts to decrease by about 10% each decade. So at 40, it's about 90%, 50, then it's about 80% of the blood flow that you had when you were younger. So your glomerular filtration rate, how fast you're actually processing the fluid that's being brought to the kidney, is decreased. You also tend to have nocturia. This is where you have to get up to pee at night. Bladder capacity shrinks, and it also shrinks in women who have had children previously because the ligaments and everything that are supposed to hold the bladder taut and tight tend to get stressed and stretched when you are pregnant. And so also the bladder can also develop bladder spasms, and that makes it harder to be able to retain urine and be able to make it to the bathroom on time. So big things to look at is going to be demographic information on your patient, looking at socioeconomic status. That's going to include things like, do they have insurance for doctors in the area? Do they have transportation to these appointments? Does their job work with them on being able to take off for appointments? Are they able to afford their medications? Are they able to eat healthy? Do they have the knowledge to be able to cook food? Or are they constantly eating processed food because processed food has higher sodium, which in turn is more difficult on your kidneys? And do they have the financial capacity to buy healthy food? We joke about college students eating off the dollar menu. It's pretty easy to find something to eat to fill you up, but even the dollar menu is harder to find these days. But it is very expensive to buy fresh fruit and vegetables for every meal. So another factor we have to watch out for is for family history of kidney issues and family history of hypertension. So if a patient has a sudden onset of hypertension and they're over the age of 50, then it's possible that it's kidney disease. If they have problems starting in their 40 to 50s, then that tends to be caused from cysts that grow up on the kidney, and we call it polycystic kidney disease. These cysts do not allow the filters to be able to work as well, to be able to clear out the toxins from the body. Over 50, problems with the urinary system, if they're male, that tends to be prostate problems. The prostate is a gland that actually wraps around the urethra in men and can engorge, fill with blood, and stop the urethra from letting urine come out of the body. Females tend to have a shorter urethra in humans. This is opposite in cats. Okay, sorry about that, guys. As I was saying, in humans, females have a shorter urethra, males have a longer urethra. And so, with the urethra being so short in females, they are more adept at getting urinary tract infections than men do. Now, in cats, this is actually the opposite. The female has the longer urinary tract, and it tends to be male cats who get the urinary tract infections because it's a shorter distance for the bacteria to travel once it gets within the urethra. So another thing that can alter the kidney function is going to be exposure to CT contrast. So with exposure to CT contrast, it is cleared by the kidney, and you need to make sure that you have good, strong kidneys before you go in and are given IV CT contrast, just because it is so hard on the kidney. So exposure to heavy metal gases, sorry, for instance, mercury, lead, or chlorine gas. Okay, and we need to do frequent assessments of the amount of urine that the person is making. It needs to be at least 30 milliliters per hour for good, clear kidney function, and ensure that they're able to drink enough. Often patients will have kidney stones. We call those calculi. Kidney function can also be decreased by patients taking medications like NSAIDs. That includes Advil, Aleve. Acetaminophen, remember, is hard on the liver, not the kidneys. You're going to need to know which medications you can take, which ones you need to avoid. if you're having problems with your kidneys. So if the urine is not able to get all the toxins out of the body, then what is happening is one of the ways that toxins are being transported to the kidney is through urea. Urea basically is, think of it kind of like a trash bag floating in the blood vessels. And at the kidney, you're supposed to be pulling out all the trash out of the bloodstream, putting it in the kidney, dumping it into the ureters to be taken out of the body. If bags of trash are being missed, those are going to build up in different places throughout the body. So uremia is the presence of uric acid in the body. This is uric acid. Urea is also excreted from the kidneys, and it's found in urine. So interestingly, birds that they actually cannot pee separately from poop. So they actually have only one hole. And so what happens is once it goes splat on your windshield, you see brown, which is their poop. You also see white, which is actually the uric acid, the urea that's being excreted. So the same thing tends to happen in people as well. Urea, you don't really notice it because it's diluted in yellow urine. But when you're having problems getting rid of it, that white will build up, and we call it a uremic frost. We often find it on the skin. And if we smell kind of like urea, kind of like pee, that's called the uremic fetor, Fetor. And that is where the chemicals build up within the breath, and you're able to smell it. Now, as you spend more time in the hospital, you'll be able to notice you walk onto a kidney floor, it will smell like pee. Your patients, even after taking a bath, will still smell like pee. And that's because their body can't get rid of all the urea. So it is coming out through the skin, and it's coming out through the breath. It's coming out any way that it possibly can get out of the body. So, general appearance, people with kidney issues often have concurrent liver issues as well. Skin tends to be very itchy from the presence of the waste products, and patients tend to have a yellowish color. They're often experiencing leg swelling, and so it's important to be doing cardiac assessments as well for their. So, as we talked about, the waste products often build up. As the waste products build up, cognition tends to slow as well because the brain is not able to really exchange its waste products and get rid of its waste products if the blood's already full of the waste products of the body. So you will start to see cognitive changes in your patient. You always want to listen before you percuss or palpate the kidneys or bladder. So always listen before percussion and palpation because that can change the bowel sounds. So always listen first. You want to listen for a bruit. You're going to listen for a bruit on the person's back. It's going to be mid-clavicular line, and that will put you right over the renal artery. You also can hear it on the front as well. It tends to be easier to hear on smaller people, and also palpation needs to be done easier, not push as hard, more gently on someone who's small. Because if there is a mass or an aneurysm, it is possible to cause those to rupture based upon your palpation of that person. Diagnostic assessments. So we're going to be looking at blood tests. We're also going to be looking at urine tests. So some of the blood tests you need to be aware of is going to be your creatinine levels. Okay, if your creatinine levels are elevated, then what does that mean? It means your kidney is upset and it is not able to function. It's in distress. It's yelling for help. So, creatinine measures the breakdown of muscle and protein in your blood. Creatinine is also excreted in the urine. So, when we compare the amount of creatinine in the blood and the amount of creatinine in the urine, we can actually compare those two factors through a creatinine clearance. So, we're looking at the levels within both. So, if your creatinine is doubled, so basically it's 2.4 instead of 1.2, then you're looking at a reduction of over half in your GFR. So your kidneys are not, they're trying to keep up, but they just can't. A BUN looks at the excretion of nitrogen, the urea nitrogen within the blood. It will be elevated in infections because cellular destruction from the immune system will elevate the BUN. It's also elevated frequently in cancer and if a person is taking steroids. Another lab test is cytostatin. Let me spell this for you. Cystatin, cystatin C. So this is an indirect modifier of GFR. So it's another indirect way that we can measure the person's GFR. So blood osmolality and osmolarity, this is the same as specific gravity. So blood osmolarity increases your blood, I'm saying in air quotes, gets thicker with less water absorption. And so your blood osmolarity will increase if you're not absorbing or drinking as much water. Now looking at urine. So in a normal person, your specific gravity of your urine should be a little over 1. Okay? So a specific gravity of water, okay? Specific gravity of water is 1. So your urine should be water with some chemicals in it. So that acts as a way that you can see how much fluid is on board. The more fluid that a person has and is peeing out, their osmolarity, their specific gravity of the blood is going to be about 1.005. So it's going to be very, very close to 1. If as they have more things concentrated in it, for example, the first pee of the day, then it will also have a higher specific gravity as there's less water and there is more concentrated stuff within that. Your urine can have large molecules like proteins. One of the more common proteins is going to be ketones. Ketones are involved in fat metabolism. Albumin byproducts. Remember, we talked about albumin. The liver makes albumin and absorbs albumin. So we can keep the fluid away from the third spacing and keep it in the blood where it should be. Glucose should not be in the urine. However, we often see glucose in the urine in patients who are diabetic or who are, we call it spilling sugar in the urine. So we can see glucose within the urine as well. We can also see nitrates will be present. Also, we can see white blood cells, and both of nitrates and white blood cells indicate a urinary tract infection. So if we have calculi, remember we talked about calculi is what we call kidney stones. So these are crystals of uric acid mixed with other forms of metals that creates crystals. So one of the big forms of kidney stones is going to be calcium oxalate. Calcium oxalate, when our patients have kidney stones, some of the ways that we can get it out is just pass it whole, have them drink a lot of water, have them take diuretics to help increase the amount of fluid, and ideally flush away that kidney stone as well. Problem is, kidney stones get stuck and they are very, very painful. And so, with this, you may have to have that stone crushed before it is able to be passed out or passed through the body. And so that may be another factor that you're looking at. So on your imaging assessment, there's a lot of different radiology tests that can be done. You can have a KUB, which is an X-ray of the pelvis, and that's going to show your kidney, your ureters, and your bladder. Can have CT with or without contrast. Remember, CT contrast really hard on the kidneys. Also need to know there is an interaction between metformin and CT contrast that can further disable the kidneys. So metformin has to be held after you've had a CT contrast, ideally for 24 hours before and 48 hours after receiving the CT contrast. MRIs can also look at your kidneys. You can do ultrasounds, renal scans, and look at the arteries as well within the kidney. Cystoscopies, this is where we look at things with an endoscopic camera. So we can do a cystograph or a cystourethograph, and this is done in fluoroscopy. So the contrast is fluoroscopy contrast instead of CT contrast. And we're specifically looking at the bladder when we're looking at these procedures. So retrograde procedures, we can inject below the kidney into the ureters, and then we want to see if any of the dye actually gets into the kidney tissue. So that tells us, is there backflow problems? Urodynamic studies, this is where we actually will take a straight cath and we will empty the person's bladder. Then we will take fluid and put in the person's bladder and see how much urine they can actually hold before they feel the need and their bladder contracts, they start peeing. Kidney biopsies, these are often done percutaneously under CAT scan or CAT scan or ultrasound guidance. And so these are done in IVR because these are very risky procedures and they need to be done by specialists. After the procedure, people often have flank pain. They are going in and drilling out part of the kidney and then closing it. So it does have significant amounts of pain with it. It increases the risk of infection. And afterwards, you have to lay 2 to 6 hours after the biopsy supine and not move. Okay, so that's it for this lecture, and then I will see you again in the next. Thanks. Bye.